to the next scoring system, that is the METAVIR. The METAVIR scoring system. This METAVIR scoring system is the most widely used and internationally accepted method, and it is especially used for chronic hepatitis B and C, which are the most common causes of chronic hepatitis when compared to A and E. So let's see, it is again which is similar to the histological activity index. It has grading, it has staging. Grading will denote the amount of necro-inflammatory activity, necrosis and inflammatory activity occurring within the liver is represented by grading, whereas staging, it will reflect the fibrosis. So coming to the grading, it's given a grade from A0 to A3. A means activity. So activity, that is necro-inflammatory activity, is given a score A. It is represented A. A1, A0, A2, A3, like that. A0, 0 means there's no activity at all. There's no necrosis, no inflammation. There's nothing, no activity occurring is 0. A1 is this mild activity. There's mild activity of necrosis, inflammation. So what are the components that you see here? Portal inflammation. As I have discussed earlier, the inflammation around this, in and around this portal triad is portal inflammation. This portal inflammation is mild. That means still you can visualize the structures of the portal triad. And that means small collection of lymphocytes and plasma cells can be seen or may not be seen. Mostly these are mild lymphocytes. Occasional plasma cell, that is eccentric cells with the oval-shaped cells with eccentric nucleus are the plasma cells. They can be seen, they cannot be seen. That is mild portal inflammation. And interface hepatitis, there's minimal interface hepatitis. That means the inflammatory activity at the junction of this portal triad and this hepatic lobule is mild, minimal, and there can be occasional breach of the limiting plate. This peripheral row of hepatocytes. This forms limiting plate. They can occasionally breach because there's mild activity going on in this junction. It can occasionally breach it. Occasional breaching will be present. The few peripheral, that is periportal hepatocytes, there are few are damaged. Few damaged periportal hepatocytes. And inside the lobule, that is lobular activity is very mild. Inside the lobule, very mild necrosis, spotty. Here, single scattered spotty necrosis is seen. And 1-2 apoptotic bodies. Apoptotic bodies are the councilman bodies. These are the councilman bodies. So, 1 or 2 councilman bodies with 1 or 2 occasional like spotty necrosis can be seen. That is mild lobular activity. So A1 means mild activity is portal inflammation mild. That is small collection of lymphocytes, plasma cells may be seen, may not be seen. Interface hepatitis minimal. Minimal means at the junction minimal inflammation is present. Occasionally may breach the limiting plate. Periportal hepatocytes, very few are damaged. Lobular activity within the lobule, spotty necrosis, single scattered necrosis, 1 or 2 apoptotic bodies. That is A1. A2 is moderate activity, little beyond the mild. Moderate activity again, portal inflammation is moderate. Moderate means again it is more than the mild one. It is seen in and around the portal tract. It is moderate, more than the mild one. Interface hepatitis is definite, means it is more than the mild. So it will like disrupt. It will disrupt. The interface hepatitis will come in the junction. It will disrupt this limiting plate. So there is disruption of the limiting plate, and clusters of inflammatory cells will invade periportal areas. They'll move out from this portal triad. It will move out to the junction. It is called interface hepatitis. It will disrupt the limiting plate, and this periportal hepatocyte, a cluster of periportal hepatocytes, they are being invaded by this inflammatory cells. That is definite interface hepatitis. Lobular activity will be increased than the mild. So lobular activity is increased means little more than the spotty, little more than 1 or 2 apoptotic bodies. So little more than spotty necrosis means confluent, a cluster of hepatocyte necrosis is called a confluent. Confluent necrosis means cluster 1, 2, 3, 4 hepatocytes undergoing necrosis, confluent necrosis, and apoptotic bodies are more than the mild. In mild, only one or two council bound bodies are seen. Here, more than two council bound bodies. One, two, three, four, like that. More than two apoptotic bodies or the council bound bodies are seen in this moderate activity. So, there's moderate portal inflammation. Interface hepatitis is definite, means it will disrupt this limiting plate, and a cluster of this inflammatory cells will invade onto this periportal area. And lobular activity increase means this confluent necrosis. The cluster of hepatocytes will undergo necrosis, and more than two apoptotic or the councilman bodies are seen in moderate activity. That comes under A2. Coming to A3, there is severe activity. Severe means the inflammation, portal inflammation is marked. That means entire obscuration. That means entirely the portal triad is totally obscured by this dense inflammation, and this dense inflammation contains plasma cells visibly. So there are many plasma cells present in this marked inflammatory infiltrate. This marked portal inflammation entirely obscured. The portal triad is entirely obscured by this infiltrate, and it contains visibly plasma cells. And interface hepatitis is extensive. Extensive means in this moderate, it is disrupted and the peripheral hepatocytes are damaged. Here, this continuous destruction of the limiting plate, entire limiting plate, from here, everything. It is continuous destruction of the limiting plate, and the inflammatory cells will penetrate deep into the parenchyma. It will penetrate deeper. It will penetrate deeper. It will disrupt the limiting plate, penetrate deeper. That comes under the severe activity, extensive interface hepatitis. Lobular activity, what is going on within the lobule? The confluent or the bridging necrosis continues. That is, confluent is a set or a cluster of hepatocytes. When it connects two vital structures, that means from one portal triad to other portal triad, or from the central vein to the portal triad, these connections, these are the bridging necrosis goes on, and many apoptotic bodies, innumerable apoptotic bodies can be seen, and the entire lobule will collapse. Here is a representing this image representing a collapsed lobule. The hexagonal architecture of the lobule is lost. It will collapse because of extensive ongoing bridging necrosis. So this is about the necroinflammatory grade of this METAVIR scoring system from A0 to A3. Higher this necroinflammatory activity, that means high necrosis, high inflammation means more number of hepatocytes undergoing destruction. So more hepatocyte destruction is denoted by it. That means they will rapidly progress to further stage. What is the further stage? Fibrosis. After necrosis, it is followed by fibrosis. So it will indicate more rapid progression to fibrosis. That means worst prognosis. In the advanced stages, it will have worst prognosis. So higher the activity of necroinflammation denoted by the grading, more the hepatocyte destruction, more rapid progression to the fibrosis, worst prognosis it will have. This is about the grading system of METAVIR scoring system. Let's see the staging. Staging here again, it is reflective of fibrosis. Fibrosis score are F. It reflects the extent of fibrosis and architectural distortion due to healing and scarring. Once fibrous deposition occurs, it will undergo healing and scarring and retraction. Because of this, entire lobule architecture is lost. The normal architecture is lost. So it will reflect fibrosis and architectural distortion. The staging will reflect it. Staging again, it is classified as from F0 to F4. F0, 1, 2, 3, and 4. Let's see one by one. F0 means there's nothing, no fibrosis. Absent fibrosis is 0. So normal liver architecture is maintained. Liver architecture, that is this classic hexagonal hepatic lobule containing portal triad, central vein, the hepatic plates, everything will remain normal because there's no fibrosis. Coming to F1, the portal fibrosis without septa. That means after this portal inflammation, here it is followed by deposition of fibrous tissue. This portal fibrous expansion. So This fibrosis is present without any septa, so it is limited to the portal triad. It does not give out the septa into the lobule. There are no septa given out into the lobule. The fibrous deposition is confined to the portal triad. Without septa is F1. Without septa is F1. So it is indicative of early scarring confined to portal tract. Obviously, no septa. It is confined to portal tract only. So septa, it is scarring will be confined to the portal tract only. No septa given out into the lobule. F1 is like self-limited. It is limited. F1 is within its limits. It knows its limits without any septa. F2, coming to F2, there is portal fibrosis with few septa. Now it has crossed its limits. So there is fibrous deposition in the portal tract, few septa, gives out few septa and few septa. So the septa, it will have with few septa, and the septa begin to connect portal areas. So here there's one fibrous here in one portal tract, this fibrous deposition, septa will be given out and towards one another, and the septa will connect these two portal areas. So septa beginning to connect the portal areas comes under F2, F2, two friends, two friends. So two portal areas that connecting. So F2 has the septa begin to connect portal areas. F3 is it has crossed its limits to further extent. So numerous septa without cirrhosis. Numerous means again from this here, numerous such septa given out. Numerous septa given out without cirrhosis. Cirrhosis means, as explained earlier in that histological activity index, there is regenerative nodules surrounded by bridging fibrosis. That nodules, everything is absent. Only it's like given out the septa, more extensive septa is given out. There is a bridging fibrosis. Bridging means again connecting two portal or central portal fibrosis is present. The lobular architecture will be even still recognizable. You can still recognize this hexagonal structures with hepatocytes, portal tracts. It can still be recognizable in this stage of F3. There are numerous septa given out, numerous septa given out without cirrhosis. That means it is a bridging fibrosis between portal or portal central. The lobular architecture still recognizable in F3. In F4, there is complete cirrhosis. That means complete architectural distortion with regenerative nodules. The septa becomes so extensive that it will surround the hepatocytes. These hepatocytes, after necrosis, it will try to regenerate. That is called regenerating hepatocytes. So around this regenerating hepatocytes, the septa will extend to such extent that it will surround it will form a nodule. These are called the nodules. So they are complete. Here now you cannot visualize the architecture. Normal architecture is not seen. So there is complete distortion of this architecture with regenerative nodules. All these regenerative nodules surrounded by the septa will distort the architecture that is seen in F4, which will denote complete cirrhosis. So as this fibrosis increase, that means as it progresses from F0 to F4, the blood flow is cut off, it is obstructed. Why? Because the regenerative nodules will be surrounded by thick fibrous bands, it will constrict, it will restrict the blood supply, it will restrict the flow of blood. Here, blood should flow from here, from the hepatic artery and portal vein, blood should flow towards the hepatocytes. This blood flow is cut off because of this fibrosis. The fibrous bands around these regenerating nodules will cut off the blood supply. It will cut off the blood supply. So there is complete obstruction to the blood flow. So because of which, like a liver is not unable, the hepatocytes are unable to receive the blood supply. That means this portal, hepatic artery, portal vein, all this the blood becomes stagnant. They are unable to flow towards the liver. It becomes stagnant in this vein, in the portal vein that carries blood from the spleen, from the pancreas, from the intestine. So the blood becomes stagnant in the portal vein. It will lead to portal hypertension. It will lead to portal hypertension. Because of portal hypertension, it will backflow. It will backflow to the spleen. It will cause splenomegaly. It will cause splenomegaly. Also, because of portal hypertension, there are esophageal varices. Esophageal varices. Also, ascites that we have already dealt in complications. All these are because of this portal hypertension and hepatic insufficiency. Why? Because of this regenerative nodules surrounded by this fibrous bridges, all these bridges of dense fibrosis, because of cirrhosis, it will form cirrhosis. Because of cirrhosis, portal hypertension, hepatic insufficiency develops. This is about the fibrosis seen, that is, which is reflected in the staging of this METAVIR scoring system. So these are the two scoring or the staging grading systems for chronic viral hepatitis. So we have dealt with the ISHAC, or the Modified Nodal Histological Activity Index, which shows you grading reflective of necroinflammatory activity based on four components: interface hepatitis, confluent or bridging necrosis, intralobular necrosis, portal inflammation. That interpretation I have said, score of 1 to 18, and staging, which is reflective of fibrosis, given a score from 0 to 6. In METAVIR also, it is the most widely used. There's a grades from A0 to A3, and again the staging system, that is fibrosis, given score from F0 to F4. This is about the grading and the staging systems for chronic viral hepatitis. If you like this video, please like, share, and subscribe to our channel. Thank you, everyone.